Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has two companion published articles, number 31 and number 32. Welcome to the Pain is Not the Only Problem podcast. Article 31, Pain is Not the Only Problem. Treatment Plan, Part 1. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction in clinically meaningful results, recommend a conservative, non-surgical course of care to override pain instantly and restore ADLs and patient confidence on the first visit at low cost. The clinician's qualifications and scope of practice will determine the recommended low back pain treatment. This can be a problem if the patient prefers a type of care that is not within the clinician's scope of practice. For example, a patient that prefers conservative or non-invasive care. This can also be a problem for the patient if the clinician's toolbox is limited or biased towards certain types of treatments. For example, treatments that can only be done by the clinician and billed by the same clinician. According to Mandrola et al. 2019, clinicians are, quote, content experts, enthusiasts for whatever content that they are an expert in, for example, a spine surgeon, whereas the medical conservative is enthusiastic only for that which has proven to promote health. Content experts become a synonym for devotion to the prevailing model or theory. So in essence, we're talking about this new term, medical conservative, that is following the types of care that actually provide the best outcomes for the patient and not simply types of care that are in the usual toolbox of the clinician. The medical conservative approach. We oppose medical progress and the accumulation of private wealth that accompanies it when it occurs under the pretext of science without meaningful improvement in patient outcomes, again, according to Mandrola et al., 2019. Another problem occurs when the clinician fails to discuss or recommend conservative options that are provided outside of their office or that conservative options even exist. The clinician should provide optimism towards out-of-office, cross-culture conservative options by other skilled physicians and specialists on a referral basis, especially when risk, cost, and treatment duration can be reduced. Before low back pain treatment can be prescribed, there must be significant quality reporting on its efficacy. The treatment must have high marks for effectiveness with least consequence to the patient, including accessibility and cost. A treatment plan should not be prescribed simply because it exists or if it is the clinician's treatment of personal choice. Treatment should address everything involved with current patient care, including everything from the patient's problem list, not just focusing on a specific current lesion. The care should be designed as a plan, including patient education and choice as described and explained in the report of findings. A prescription for epidural injection is not a treatment plan for low back pain. Clinicians should include cross-culture care and treatment models with high efficacy at low cost and low risk. It is uncommon for a medical doctor to prescribe coordinated chiropractic care, acupuncture, Chinese medicine, or naturopathic care. However, the inverse is not true. According to Dean 2016, conservative chiropractic care for non-traumatic and non-specific low back pain and low back pain surgical failure can be resolved in as little as one treatment at low cost. A low back pain treatment that only addresses patient symptoms such as pain should be considered borderline malpractice. According to Sarman 2017, the physician has minimal knowledge of muscle and movement function. Anatomy and the physical exam are not a major part of practice. Not only is the physician knowledge limited in these areas, but there is also limited appreciation for the importance of movement and the role of contributing systems: neuroendocrine, nervous, cardiovascular, pulmonary, integumentary, and musculoskeletal. Few physicians were interested in the specifics of the movement disorder and were more interested in the nervous system lesion itself and what type of medication could be used to alleviate symptoms. Conservative treatment, reducing the need for drugs and surgery, is cost-saving and optimizing the human experience. Any clinician's treatment prescription is restricted to these 6 things. 1. The scope of practice within the office. 2. The clinician's biases about care. 3. The clinician's schedule. 4. The clinician's biases about referral to cross-culture practices. 5. The clinician's ability and willingness to provide ongoing care monitoring. And 6. The clinician's scope of knowledge regarding whole body health systems. According to Cousins et al. 2018, in the absence of evidence from well-designed and conducted RCTs, clinical practice has been largely driven by personal preference, personal experience, and anecdote. A patient's treatment options are therefore limited to one type of care recommended within the clinician's office, likely invasive, that is convenient for the clinician's schedule, ability to provide ongoing monitoring, and limited to treating only symptoms. Invasive treatments include injections, surgeries, drugs, and coercion. Invasive is not only defined by the type of treatment, it is defined by the attitudes of the clinician. A treatment plan should be chosen at the discretion and approval of a well-informed patient, not forced on them. Treatments are invasive if there is a likelihood of drug addiction and when the addiction is not monitored nor addressed by the clinician. Treatments are invasive when the clinician is insensitive and disrespectful regarding the needs of the patient to function safely in their everyday life while under the influence of pain drugs. The patient can't drive, perform certain work duties, care for children, make important decisions, functionally relate. In other words, the drug creates worse problems than the low back pain and likely endangers the patient. The act of treating patients is a pursuit to provide sustainable, coordinated medicine, not to be a hero. Conservative care should be the gold standard for non-specific, non-traumatic low back pain. Patients should be informed about the severity of the risks involved with invasive types of care and the likelihood that the invasive care may actually manage the problem, since pain is not the only problem. Article 32. Pain is not the only problem. Treatment Plan, Part 2. Prescribing a treatment plan is more of an art than a science. There is sufficient research available to describe our many attempts to observe and report patterns in treatment success. Scientific research looks for patterns of correlation and causation among treatments, then compares them against each other, searching for the music in the noise. However, the results are commonly insufficient enough to proclaim victory. Therefore, prescribing might be best described as an art, an application of human creative skill and imagination acquired through practice, according to Merriam-Webster.com. Let's look at the definition of the word treatment. According to Dean 2016, treatment is defined as the manner in which someone behaves or deals with someone or something, their conduct. In the clinic, treatment often implies a therapeutic application, the administration of care on behalf of the patient's well-being. Since patients are individually unique, each prescription of care or treatment should be individualized. The treatment becomes an art. Let's look at the definition of treatment plan. According to Dean 2016, treatment plan is defined as a proposal for a manner of behavior, conduct, or therapy on behalf of the patient's well-being. In the clinic, treatment plans begin with a discussion of the report of findings. Then the clinician proposes a plan for the administration of care. Treatment plans are customized to meet the individual needs of the patient, their values, and expectations. Since no two patients are alike, the plan becomes an art. Let's look at the definition of course of care. According to Dean 2016, the definition for course of care is a proposal for the entire duration of the treatment plan that includes resolution of the problem list using an agreed strategy involving primarily patient contributions along with the clinician's ongoing conservative coordinated care advice, with a personal and professional warranty that the best outcomes will be possible with the most economy of the patient's time and finances and at least risk to the patient. Let's look at the definition of coordinated care. According to Dean 2016, the definition of coordinated care is the physician's ardent commitment to expedite patient healing by respecting and involving cross-culture care with optimism. Let's look at the definition of treatment reasoning. According to Dean 2016, treatment reasoning should represent one standard of care. Treatment reasoning should never change when considering patients' social economics, ethnicity or skin color, religious or spiritual beliefs, gender or sexual identifiers, fear, bias, prejudice, preference, mood, or clinician's personal financial gain. How many patients would you treat using a specific treatment strategy or plan without realizing your predicted outcomes and expected patient satisfaction before you would abandon that treatment plan? This is known as the number needed to treat, NNT. Again, how many patients would you treat using your specific treatment strategy or plan without realizing the predicted outcomes that you expect and expected patient satisfaction before you would discontinue that treatment plan? Do you commonly prescribe the same treatment plan without any regard to the occurrence of the predicted outcomes or predicted patient satisfaction simply because it is the treatment plan that you offer? The number needed to treat, or NNT, describes the total number of patients that would receive a specific treatment plan in order to get results from one patient. For example, when the NNT is lower, the occurrence of benefit is high. The NNT for statins is commonly around 300. For every 300 patients on the statin drug, only one gets satisfactory results. The other 299 patients pay for the drug and take it every day without satisfactory results. In another example, the NNT is 5. This means that for every 5 patients that receive a treatment plan, 1 patient receives benefit. This is a higher occurrence of satisfactory results. Treatment reasoning includes an NNT with patient satisfaction determined at 12 months. Therefore, if an epidural injection is prescribed to treat low back pain, the patient should be informed that the NNT is infinity. This means that the patient satisfaction for epidural injection is 0% at 12 months, according to Weinstein et al. 2016 and many others. A well-organized treatment plan is a billable service, so there is no need for the clinician to take shortcuts. E&M coding allows for 10 to 50 minutes or more if consulting or review of records is required. A well-organized treatment plan should include these 7 components. 1. A brief conversation with the patient to discuss the ROF. This should take no longer than 3 to 5 minutes. 2. A brief conversation with handouts to discuss an anti-inflammatory low histamine diet. 3. A handwritten flow chart that maps out the patient's course of care. 4. a list of costs and, of course, stores where these items can be bought for therapy and nutrition supplies. 5. A timeline of expected recovery with milestones. 6. Access to self-help content, whether it's the clinician's YouTube channel or website or other handouts. And 7. Direct access to the doctor for troubleshooting, either an email, a cell phone, text, message center, blog board, online chat, etc. Yes, I did say it. Direct access to the doctor for troubleshooting. The clinician makes it clear that there is never an option to abandon the patient's care. If the clinician is unprepared to promise long-lasting resolution of the patient's low back pain and associated faulty motor patterns at low cost and low risk, the clinician should refer the patient to a capable local practice that is getting excellent results with high marks for patient satisfaction. Finally, a reminder that the treatment plan is a proposal. The patient is not required to accept it. Clinicians should be prepared to modify the proposal until it suits the patient. The patient should not be coerced into the clinician's preferred treatment plan or shamed or scared into a certain treatment. Clinicians should include other cross-culture care clinicians in the treatment plan. Low back pain is notoriously self-resolving with minimal monitored conservative care, especially with lifestyle, diet, and smoking changes, since pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.